So welcome to week 6 of BMI 598, Pop Health Management and Analytics. As usual, I'm your instructor, Ken Farrell. So today we're going to take a look at how to analyze a Pop Health initiative. We're going to be building on quite a few of the items that we've been discussing in week 1 through 5, and this week really starts to tie, I believe, starts to tie everything together quite a bit. So what we're going to do this week is we're going to review the process of building a Pop Health initiative. That is, we're going to review everything that we've talked about in the previous weeks 1 through 5, mostly weeks 2 through 5. We're going to identify the different ways to track the progress of a Pop Health initiative. We're definitely going to get into some errors that can be made when analyzing Pop Health initiatives. Now, I'll be going into the 7 plausibility rules of Pop Health analytics. We're going to look at the life cycle of a Pop Health initiative, and also we'll be reviewing some case studies of Pop Health initiatives and identify relevant aspects of those studies. And then we'll take a look at the role of third-party vendors in the Pop Health space, and we'll take a look at some sample dashboards that some of these vendors have to allow the tracking and analytic analysis of Pop Health efforts. So let's take a quick review of weeks 1 through 5. So we've talked about to create a Pop Health initiative, whether you're doing this for a community, whether you're doing it for an ACO or a large hospital system, or even a state government, you need to identify the population and a problem. And we did talk about creating a cohort and assigning a risk level to those cohort members. So whether they are a cohort of diabetic patients, whether they're a cohort of disadvantaged youths, that is, you would want to put some parameters around your cohort, and then once you've identified a problem, what the problem that you're trying to address, whether it's overall health or whether it's a specific disease state, you want to create some sort of risk around those members. As you member, you can't, it's almost impossible to address every single person in a population. You need to basically find your high value opportunities and those that would actually respond to some sort of intervention. So we talked about quite a bit about that in week 2. Then we need to identify what metrics we can use to track the progress of that cohort. And you have to identify the availability of the data that you may need for these metrics, whether these metrics are actually relevant to what you're trying to track. You definitely need to take a look at whether you need to include balancing measures or not. I will talk about those in some detail. You also need to identify baseline values. So what is your starting point? What is your current state of efficiency? And then identify the improvement efforts. So we talked about in accountable care organizations, you can't just have a small improvement because there's a cost, an overall cost of just creating the program. Independent of any costs you may have with a particular intervention on a particular individual. There's going to be costs for people like me that do the analysis, as well as people that train and manage the process. And then you need to implement some sort of change. So you've identified a population, identified a problem. Now you've stratified those patients. Now what are you going to do to make a difference? Is it going to be education? Is it going to be engagement? Is it going to be some sort of change in their behavior that you're going to track? So what are you going to do? Is it coordinating their care through the different continuum, through outpatient, inpatient, and emergency room? What is it that you're going to do? So you have to come up with a very viable process change that you're going to implement to affect these patients in a positive way. So part of Pop Health Analytics is identifying the temporal expectations of improvement, and that's really a very complicated way of just saying how long is it going to take to see what improvement. Again, we talked about balancing measures, and we're going to talk about this a little bit later. You can always improve one measure if you don't care about other measures. We made some examples about this. You can always improve outcomes if cost is no object. But you need to include balancing measures so you ensure that you're not improving one area of providing care without damaging another area. You need to attempt to capture the triple aim components. So we've talked about these virtually in every week of the course. So cost and outcomes and patient satisfaction. And we'll talk about this as we get further into the lecture, but patient satisfaction, potentially could be the most difficult measure to gather. And then you need to design with your programming or IT folks visualizations of the metrics will help you actively manage your initiative and stay on top of it and know if it's going sideways or whether it's actually returning benefits to your organization and to patients. And be able to quantify those improvements as well. So one concept I want to talk about, and this is something that's problematic in population health and analytics, is something called regression to the mean. So regression to the mean basically is a statistical concept that says when you have outlier data elements, so in medical terms, you have a patient that has a high cost year, or a patient that has a significant medical event, like let's say a heart attack, or they're first diagnosed with diabetes because of some medical presentation. If you just track those people that had a significant event in, let's say, last year, and you compare their costs this year to last year, their costs this year will tend to regress to the mean, so that they'll tend to come back to the pack as far as cost. And if you think about this in medical terms, and those that are clinicians in this in the class will understand, if somebody has a significant medical event, there's going to be a significant cost. So if you have a heart attack, that's a significant cost. Potentially you could be an inpatient, you may require surgery. But in the following years, you're going to be managing that condition. You're going to be focusing on managing a condition that you wouldn't have been focused on prior to the event. So if someone has a heart attack and they incur $25,000, $50,000 in medical costs, and you put them into a cohort and say, we're going to manage these patients that just had heart attacks, well, the follow-on year is not going to be as expensive as the first year for those patients. And that's because of this regression to the mean concept, which is well understood and pretty much assumed to be a fact when you're looking at things like medical events. So the graph here, and I pulled this graph from a very nice paper called Assessing Regression to the Mean Effects in Healthcare Initiatives. The paper I was going to post as reading, but it gets a little mathy and it's quite long, and really all you need to know, if there's just a few concepts you really need to take home from this week, and one is regression to the mean. So outlier years are typically followed by non-outlier years. Now I would think that would probably also extend to the reverse. So if you put a cohort of patients together that had virtually no medical expenses in a year, chances are in the following year they will, as a group, have slightly higher medical expenses, and even a few of those people might have significant medical events. There's a little chart here. It's graphing first year and second year costs, and these are for three specific disease cohorts of patients, and you can see that first year costs are around in the $20,000 to $30,000 range, but the second year costs are more in the about $7,000 to $15,000, and that is a natural effect. So when you go to put together your analytics and you're developing the plan and you have the metrics, be very cautious in creating a cohort of people that had significant events or significant costs in a year. That will show potential benefits to a program. Even if you didn't implement anything, you'll still see, as this graph illustrates, you'll still see significant savings, and you can go to your executives and say, wow, we focused on these high first year cost patients and we're able to keep their costs 50%. We're able to reduce costs 50%, when in fact nothing really, you didn't do anything. It's just, this is a natural phenomenon of medical regression to the mean in the medical field. You can find all kinds of papers and additional literature on regression to the mean if you're interested in learning more about it, even from a mathematical standpoint. But just understanding the concept that outlier years are typically followed by non-outlier years for statistical reasons and for medical reasons, then you'll be good to go. So identifying your year-over-year populations, and most or a significant amount of pop health efforts are evaluated by looking at some sort of temporal comparison. So year-over-year, quarter-over-quarter, maybe even 5 years over 5 years. So you can evaluate whether or not the program is actually having the desired outcomes. So what you need to do is identify a cohort, define your population in terms of demographic and health state. So again, stay away from things like high cost or significant episodes of care, and look more towards building a cohort of similar patients. So you might just be looking at patients that have been diagnosed with diabetes in the last 2 to 5 years, or patients that have COPD, and generate this cohort of patients and track them. And what you want to do is you want to actually look at a baseline period. So if you find a similar cohort, and what you'll see, cohorts from year to year won't be the same patients, but what they'll be is the same kind of patients. So for instance, you might take a cohort of patients that are diabetic patients, and you might look at all the diabetic patients that you managed, regardless of the severity of their diabetes. You might have some minimum threshold, but look at all your diabetic patients in year 2015, and then compare what happened to those patients in 2016. So you might see maybe their costs went up, maybe their trips to the ED went up, or maybe their trips to the ED was they averaged 4 trips to the ED, and the average cost of caring for those patients was $20,000. So now you have a benchmark you can compare against a cohort of patients that you put together in 2016 and that you've been managing throughout the year, and then take a look at what happens to them in 2017. And you're hoping to see a reduction in outcomes, hopefully improvement in overall care, and improvement in patient experience, the triple aim, of course. So your cohort in 2015 might be different patients in your cohort in 2016. Cohort in 2016, you may have some people added to the diabetic registry, and in 2015 cohort, you may have some people that left the program or left the ACO, or unfortunately may have passed away and are no longer receiving care from your organization. So although your cohort from year to year may not be the exact same patients, the overall composition of those is the same. So you would hope if your ED visits per patient in that cohort in 2015 was 4, your 2016 cohort hopefully drops to 3.5. That would be an improvement, that you're managing your diabetic patients better. And again, you would like to put some parameters around your expected improvement, because you're going to be outlaying some costs and some resource allocations in order to achieve this improvement. You want to, and we talked about this, I believe, in week 2 or week 3, the calculation of how much does the intervention cost and how much you're going to save per patient, and then the probability that your intervention will actually have an effect on the patient. All of that comes to become a mathematical formula. So you need to project. So if you think you can only reduce it by 1/10 of a day, the cost benefit may not be there. But if you think you can reduce it by a half a day length of stay, or you can cut out 1 ED visit per year from that cohort, then it might be something that you can show benefit for. So you need to identify the expected improvement, and then you track it against a baseline. So you have your baseline, you have your $20,000 and your 4 ED visits for your cohort, and you want to show that you've reduced those. So you'll track it against your actual performance against baseline, and you don't want to wait for the period to be over when you do that. You want to be doing that right out of the gate. So you have to understand the confidence of the numbers that you're seeing early on, not to get too panicky if the numbers don't look good in the first month or 2, because there may not be enough data to really identify any improvement. And some of these programs take time to kick in, so there's also sometimes a lag of education down to the clinicians. So in month 1 and month 2, maybe the word really hasn't gotten down, the physicians haven't really gotten used to the new protocols, and you can track the movement, and then you can even track it sometimes at a physician level and figure out where the improvement needs to happen as far as education or training or any other efforts that you are going to employ to get your plan, your new intervention working across the enterprise. So this is something that's important too. So there's a lot of studies that will say, hey, you know, we reduced our high-risk population. We were able to take our high-risk population from year one, and we were able to move 10% of those people out of the high-risk bucket. Well, that sounds great, but you need to pay attention to where the movement is by patients or by beneficiaries in all risk strata. So here you can see we started on the left, 253 individuals in the high risk category. Let's say this is a cardiac, some sort of cardiac high risk group, and 227 of those 253 stayed in the high risk, but you're able to move 21 patients into the medium risk, and 5 actually, for whatever reason, went to low risk. So if that's all you publish, hey, you know, we reduced our high, you know, 253 of our high, we had 253 high-risk patients, and 26 of those, almost 10%, over 10%, were able to move out of the high-risk category. That sounds great, but you need to see what's happening to the rest of your risk buckets here. And so what you see is 61 of the medium-risk people actually moved into high risk. So the net change on that high-risk category is actually they had 41 more patients in the high risk at the end of this period than they did going into it, just because of the movement of patients through the risk categories. And a lot of this is natural. There are high risk patients that once they get a diagnosis of high risk, they may work with clinicians and actually get their risk down. And there are patients that are medium risk that their disease state just progresses, and then they're now into a high risk category, whether that's measured by specific lab results or just an overall evaluation of risk, or some sort of predictive model to predict their risk. Patients tend to move around very fluidly, so you need to focus on not just one group from one year to the next, but where all the patients are moving within the risk strata. So another big reason to do these pop health efforts, or something that's actually a predecessor to some of these pop health efforts, is something called comparative effectiveness. And if you're not familiar with comparative effectiveness, I actually uploaded quite a few documents on comparative effectiveness. And comparative effectiveness is typically done in 2 ways. And let me just first talk about what it is. Basically, comparative effectiveness is looking at 2 or more ways of providing care to a particular type of patient or type of problem, trying to identify if there is one way that's better than the other. Typically, if you have some condition where physicians diverge in their clinical pathways, or clinicians diverge in their clinical pathways, one is better than the other. There's rare is it exactly equal across the board. So, for instance, if you have a patient that needs a hip replacement, there are multiple procedural ways to replace a hip, and there's also multiple devices you can use. There's different pain medications you can give. There's different rehab therapies that can happen. There's a variety of strategies across different areas, again, whether it's device or whether it's rehab protocols, that can have an impact on patient outcomes, patient experience, and cost. So comparative effectiveness are ways to determine which way is the best when there are competing options. It could potentially be different drugs being used to treat a specific disease, different devices being used in ortho procedures, or just different protocols, clinical pathways that are being implemented for specific patients. So comparative effectiveness can typically happen 2 ways. One is through sort of RCTs, so randomized controlled trials. The other way is through retrospective analysis. And typically when you're looking at pop health efforts and you're trying to determine which way is the best way to go when it comes to a pop health effort, retrospective analysis is a very powerful tool to do that. So you're able to actually look back into your own data, times when you had those patients with a particular condition, or particular presentations, and they were given specific protocols, whether it's drugs or devices or rehab or just different interventions, and you separate those into your own clinical trial, if you will, and then you determine which ones actually had better outcomes over the other. And then as long as you control for a lot of things that potentially could confound your analysis, you can make the determination that this is what we're going to do across the enterprise, and then it becomes potentially a pop health effort. This is AHRQ's definition of comparative effectiveness. It's basically, like I said, drugs, medical devices, tests, surgeries, or other ways to deliver healthcare. So this is also from AHRQ, and this is just basically the reasons for doing comparative effectiveness. And primarily, we focus on the first one, identifying new and emerging clinical interventions that are better than maybe the way you're doing things now, or maybe the way that some people are doing things now. There's also a variety of other reasons to do it. Identifying gaps between existing medical research and the needs of the clinical practice is a huge one. I read a study once that said when physicians actually have questions about how they should treat a particular patient that's before them, medical research that is best practices only exist for about 20 to 30% of those questions. The rest of the questions they have, they're basically left to their own experience, their own intuition, and their own education, and those things can vary widely between different clinicians. So when they go to look for that information about how to treat a patient, oftentimes it's not there. Comparative effectiveness can actually be a very good tool to provide that information. And in fact, there is, and I believe I posted this last week, there are programs that you can run, computer programs that can very quickly identify multiple cohorts of patients from existing data based on the type of patient that you want information about, specifically about their conditions and their age and their gender and their ethnicity, what medications they're on, and will attempt to provide you with information about the best way to proceed. And that will probably in the next 5 years becoming more to the front line of care. It'll be something that's, instead of just looking up information that already exists, programs like Up to Date that are integrated with an EHR allows clinicians to research medical literature on the fly. It will actually be a little more evidence-based from your own data, not from existing research publications. So there is a concern about bias in comparative effectiveness research. And what it means is that if you're looking at two different treatment protocols, whether it's a device or a particular using one drug over another, or one clinical pathway versus another clinical pathway, or one method might use an intervention and another might not use the intervention, you have to be careful if the antecedent probability of a patient being in one of the two or more groups differs between those groups. So for instance, if you have a particular hip replacement device that you tend to only use on younger patients as opposed to older patients, looking at outcomes of length of stay could potentially be confounded by the fact that device A gets more young people than device B, and length of stay is already correlated by age. So older people typically stay in the hospital longer because it takes them longer to recover. So you have to be careful with that bias when you look at retrospective data. The reason is when you look at retrospective data, you don't always have the ability, like you do in random controlled trials, of making two perfectly homogeneous groups that you can then apply a particular treatment to. You're relying on what really happened in the past, and that is not controllable. That's already happened. It's a matter of record. So there are ways, one method is called propensity scoring, that you can leverage, and I'm not going to get into the math of propensity scoring, but it can help you leverage these tools that will eliminate the bias and determine, and look at the results and determine whether or not there's really a difference between the two groups. And again, this is very important in retrospective studies. When you're looking at random controlled trials, typically you can set those up with the patients that you want in each group, making sure that they're well balanced between the two groups in virtually every potential category that you're concerned about. So this is a fantastic book. I highly recommend, if you're going to go into population health and you're going to get involved at all in statistics, you read this book. Al Lewis is somewhat tongue-in-cheek at times. It's a very easy read. He has quite a bit of humor interjected in here, but he basically says, look, there are 7 rules to what he calls plausibility testing of population health analytics. And whether you're reading a study or getting some literature from a third party that says, hey, our software can help you achieve this, this is what we found at other sites, really need to take that with a grain of salt. These companies are out there to get you to sign contracts, and quite often their own literature is a bit misleading. And this book walks through several case studies that have misleading literature, and Al presents these 7 rules of plausibility testing. So anytime you're thinking about implementing a program that maybe that third party is bringing to you at a cost, or if you're even developing your own analytics and you see some numbers coming out of it, follow these rules to determine whether or not maybe what you're looking at is maybe not what it appears to be. So the first one is the every metric can't improve rule. So that basically says that everything can't go. You're going to have something that's going to go the wrong way. So for instance, if you're trying to improve management of diabetes and part of that management involves an intervention that requires a visit to the doctor, there's going to be an increase in cost when it comes to doctor visits. So you can't really reduce every element of cost and see every outcome improve. It's just if they're making those arguments that their program does that, is probably they're probably playing a little footloose with the numbers. The 50% savings rule basically says in a voluntary health management program where there's really no incentives, decline in excess of 50% typically is not valid. It's typically something that's manufactured through some fancy math. The nexus rule I really like, and this basically says that in order for your intervention to show benefits, there must be some logical reason why it does so. So if you just identify an intervention that you're going to perform and you see these amazing savings, but there's really no rationale to why that happens, then you really have to dig a little deeper and find out what's going on. The quality dose cost response rule, and basically what this says is if your intervention actually should take a considerable amount of time before it shows results, you shouldn't see results right away. There should be whatever delay you think that naturally should happen because of an intervention. You should see that in the data, and quite often you'll see testimonials that are contrary to that concept, that they say, oh, in year 1 we realized this savings, and when you take a look at the interventions, you realize these interventions are long-term interventions. They shouldn't have seen any major savings in year 1. So that's rule 5. Rule 6, the cost control equivalency rule. And this basically says that control groups, if not prospectively sorted into 2 similar or equivalent groups, you're going to see some misleading analytics come out of that. And we're going to talk a little bit later about some of the ways that you can prospectively look at data, group people into 2 data sets that may not be exactly homogeneous across all different parameters of disease state, progression, and demographics, and age, and gender, and all that, but you can still use some techniques we'll talk about later, and there's some of the readings talk about this, to be able to compare those 2 cohorts and determine whether or not there's a difference. But the control group equivalency rule says that you just can't take 2 groups that are not homogeneous and compare their outcomes. And 7 is the multiple violations rule. It basically says that if any one of these is violated, then there's probably something else. There's going to be another one in here that's violated. And the one I missed is the 100% rule. So the 100% rule basically says that you can't decrease cost or resource utilization by more than 100%. And it sounds intuitive, but I've actually seen this myself in practice where they're claiming 150% reduction in something, and I just kind of chuckled because I know the rule, the 100% rule, is being violated here. So I actually recommend, if you're going to be in pop health, around anything around analytics space, read this book. It's a good book. It actually has some great case studies in it, and it's not a terribly long read. I think I read it in 2 or 3 sittings, and it's really quite engaging. So it's a good book. good book to pick up. It's probably the most entertaining pop health book I've ever read. So we talked about balancing measures, and I thought it would be good to address them separately here. So basically, balancing measures is a bunch of metrics designed to ensure that improvement in one metric or one area of care is not being sacrificed for another. And I see this a lot. I really see this a lot where, and it's not nefarious. These are just people that don't understand that you can move the needle in one metric and you have to be cognizant of the needle moving in other directions on other metrics. So I thought I'd pull some examples here. Some of these are from examples I've seen on the web. A couple of these actually are ones that I've actually encountered in real life. So the first example is for reducing time patients spend on a ventilator after surgery, and make sure that reintubation rates are not increasing. So of course, if you just start taking people off the ventilator after surgery too early, a good portion of those people you're going to have to reintubate, and that's not a pleasant experience. That's something you want to avoid. So what you might do is you might have a graph with an XY. Your X might be maybe a movement in your ventilator time per patient, per surgical patient. Another one might be your intubation rates, and you can just see if those are moving in opposite directions. For reducing patients' length of stay, and this is a huge one, and these are probably the two in the inpatient space. These are probably the two most ubiquitous metrics around: length of stay and readmission. And it's a constant battle between those two. Of course, the clinicians would probably understand that the longer you keep somebody in the hospital, generally, not in every case, the longer you keep somebody in, the less chance they are they're going to come back, because they leave the hospital hopefully in better shape, their acuity level is lower, and they won't run into any complications once they leave. If you sent them home too early, you can imagine that they may develop infections. If they don't follow their medication protocols, they may have troubles with managing recovery. So you have to, if you solely focus on length of stay, sure, you can reduce length of stay. You can just tell clinicians, even incentivize them to get people out the door sooner. But that would not be good if you're not looking at your readmission rates. And you may even look at other metrics like ED visits in the next 30 days. This is one actually that we worked on as well. So we have a C-section rate focus. So as most of you know, C-sections became very popular in the 70s, 60s, 70s, and 80s, and then they determined that they were probably gone overboard on the C-sections, and that they really needed to make every effort to deliver babies vaginally when it's safe for the babies, simply because there's shorter length of stay in the hospital. It costs less money to do a vaginal delivery versus a C-section, and there are potential problems, patient outcomes, and patient experience issues around C-sections, which I won't delve into all of those on this presentation. But if you're trying to focus your physicians into reducing C-section rates, you need to make sure that you're not starting to see an increase in things like birth injury or hypoxic events that typically a C-section would be an intervention for. So we have an XY-axis, XY grid where we have the C-section rate, and typically we look at low-risk C-section rate, and then what we call unexpected outcomes, unexpected neonatal outcomes of birth injury, hypoxia, just a variety of different injuries and different neonatal conditions. So of course, whenever you're looking at a Pop Health Initiative dashboard, you want to capture the triple aim components of cost, patient care and patient experience. Patient experience is difficult. You typically have to rely on surveys that potentially are only sampled. There's quite a bit of bias in those surveys. Only a small percentage are actually returned. You can always look at a surrogate of outcomes and costs. So lower length of stay and better outcomes should be a good surrogate for patient experience. It's not perfect, but it might be good enough to make the interpolation that better outcomes and lower cost and lower length of stay would result in better patient experience. There's an IHI resource here that I listed, that I've actually listed before, that's very helpful when selecting and creating your measure. So real quickly, I'm actually going to do this in one video, so let's try and wrap this up before this gets too large, but I think one video is perfect for this. Visualization. So you always want to provide, whenever you show visualizations of these metrics to your sponsors, to your executives, you want to allow them to filter the population by date, by demographics, by risk strata. You want to juxtapose those metrics, as we talked about, with balancing measures to demonstrate that indeed your outcomes are better. And you need to provide trending information, which I always put out the caveat, especially for conditions that are seasonal, such as sepsis, flu, and this could be different from geographic region. Be sensitive to seasonality of what you're tracking. And also, it's good to show rolling month functionality. Typically, if you're looking at month-to-month trending, a lot of times you see these wide variations. So a rolling 3-month, rolling 6-month, rolling 12-month graph is always very helpful to just show the general trending and kind of wash out the month-to-month spikes and dips in numbers just due to natural variation in smaller case sizes. So these are some, I'm going to show just a series of visualization examples. I'm not going to spend too much time on these, just to give you a different idea, an idea of the different flavors that are out there. So this is one particular dashboard, and it has a variety of types of metrics. You can see volume and quality and financial, very much in line with a triple aim. And then you have the measure, and then you have the month-to-date targets. This allows you to very easily track where you are and how you're doing both on your month-to-date, year-to-date targets. This is where you should not see, so if you see improvements, and again this is month-to-date percentage from target, so this is not subject to the 100% rule, but if you're showing actual savings, this is where you would not expect to see anything greater than 100%. You can also see they do rolling 24 months like we talked about. They have targets versus actual comparison, and we saw a lot of this in the ACO metrics. Just another dashboard, very simple, looking at your different patient groups. You can see there's a drop down by provider and facility, so if you want to focus in on a particular provider, you can. You need to be cognizant of a small sample size if you do that. These don't have any confidence intervals, so you would have no idea that what you're looking at may or may not be significant. Another nice visualization, this is a dashboard tracking pop health efforts, and you can see they list a population of patients by chronic disease. They've got PMPM, which is per patient per month cost. Also, it has some balancing measures here with average length of stay and readmit likelihood. So this is just another way to visualize how your pop health program is progressing. So just a quick review of what we talked about this week. So your analytics should capture as many AAA components as possible. Again, we said that patient experience is probably the most difficult to capture. The other ones are just simply a function of having access to the data and being able to coalesce them into like an enterprise data warehouse. CER can precede pop health efforts to determine best practices, which then you can put into practice by determining that device A is better than device B. We're only going to order device A, or pathway A is better than B, and we're going to educate our providers or even enforce it through an EHR to use pathway A. Ensure your analysis or analysis that you're looking at passes the plausibility test that we talked about from Al Lewis. There are methods to control for bias if you happen to do retrospective analysis or pop health analysis, such as propensity scoring. And visualization should support filtering of data and show trending and track metrics along with balancing measures. So that concludes week 6. Week 7 we'll talk about the future of pop health. We'll try to delve into the implications of recent attempts to change the Affordable Care Act, and where pop health would go even independent of any incentives through programs or acts like the ACA.